from Norway, a leader in cognitive functional therapy and patient-centered care, stepping forward to transform how we move and live. Please welcome Associate Professor Kjartan Vibe Fersum.
Before we start, I'd like you all to close your eyes. It's not dangerous. Imagine waking up tomorrow with a constant pain in your body. Every small movement that you have will remind you of something that you lost. Loss of work, loss of sports, loss of laughter with your loved ones, loss of confidence, and loss of a future or hope. Can you imagine that? This is what we see in patients, and I want you to really feel it as well. What we see is that choices are few, hopes are scarce, and everything they do resolve around their pain. They have to decide, should I do this, should I do that, and what will my pain be like? For our patients, this isn't just an imagination, it's a reality, isn't it? They live in this reality. They live in this cycle of pain, distress, and a constant reminder of profound loss. It's our challenge, but also our privilege, to help rewrite these stories. And today, I want to show how cognitive functional therapy can be a guide to help patients move, live, and trust their bodies again. So I want to introduce you to Joe. No one, sorry. Meet Joe. So would you like to start the video, please?
My name is Joe Lawrence. I'm an emergency services worker in Perth, WA. I have a huge amount of active hobbies that I really enjoy pursuing, along the lines of running, paddle, tennis, kite surfing, windsurfing, surfing, and I absolutely love doing those things, and they mean a hell of a lot to me. I had a journey with back pain that started about 8 years ago that is now, as far as I'm aware, completely fixed. So I think that my back pain journey sort of started, like most people, with a lot of negative messaging around backs in general. But I mean, specifically for me, I feel like my journey started, I was at work and I was doing some awkward movements, lifting a hose over a fence. I felt a shooting pain go down the side of, from my lower back. It originated there and sort of went down into my hip and then shot all the way down to my ankle. Never felt anything like that before, and so it was a bit scary at the time. But then like the next few days, like it felt okay. But then about a week later, I just did a really routine movement along the same lines, and then I was laid up in bed for 2 weeks. So I guess the very first experience I had of super serious pain that I can remember was sort of then. From there, it really set me on a downward trajectory after that, involving a whole bunch of medical practitioners, a bunch of medicines, Googling, just went down the rabbit hole big time on that. Probably more like a three-year duration where things went downhill, and I started seeing the chiro. The chiro wanted to see me 2-3 times a week, and his messaging was that the only way I was going to be relieved of my pain was with constant treatment, which made me think, there's something damaged in there that sort of needs to be put back together. After seeing him, I went and saw a physiotherapist, and their advice was I needed to do a lot of core strength, always lift with a straight back, just always lifted my legs, try to avoid things that aggravated it. If it's aggravating it, that it was causing damage, and therefore I should sort of stop. And I think those messages really didn't help, but I took them away. So I did what a lot of people do, and I went and got a scan. When I got the scan back, I took that back to the GP, and he said, it's a pretty good back for a 60-year-old. Yeah.
Is that a common story we hear? How many people relate to that story in their practice? Only 30%? I would suggest 100%. So people have often this belief about low back pain. And Bendolo has said backs are easy to harm and hard to heal. We see that people believe that it's caused by injury and damage, that backs are vulnerable and needs to be protected at all times. And also painful movements should be avoided. And we know from the evidence that there's little causal evidence for these beliefs. But it seems to be a societal beliefs and a clinician's beliefs. So I'm asking you, what are your beliefs about back pain? What are your beliefs about pain in general? And we know that this can drive distress, disability, and what we call low-value care. I want to reiterate straight up front, because it was mentioned about the examination or the assessment. We're not talking about, our primary goal with any patient should be to rule out serious pathology. Let's be clear on that. Red flags, cancer, infections, and fractures. But also specific pathology, because sometimes that will drive a different path than what we are offering. But from what we know, it's only about 1 to 5%, and usually we see more of this group, the non-specific pathology. It's not to say that nothing is wrong. We know that there's something wrong with these patients, but it's not to say that we can identify a trigger or a painful structure explaining all their pathology. So that's really important that we do this triaging of the patients. So what predicts chronicity? So a lot of patients have got this belief that my back is stuffed and it will never get better. Rolf was also talking about contextual factors, past pain and trauma experiences, general health and well-being. And then somebody saying things like that, you got a back of a 60-year-old. Would you be happy if somebody said that to you when you were 25 or 30? It's not a good thing to say. So they get these negative perceptions about their identity, the cause, the consequences are often larger disability. I will never get better. And they don't feel they have any control of it. Mix that up with unhelpful coping, where you rest, you avoid, you overprotect, and you get a lot of passive therapies, but no real plan for helping yourself. And we see the consequences in disability, pain persistence, sleep disturbance, pain-related fear, distress, and depression. So it's driving this vicious circle. And we as clinicians can provide a key role in this process, not just on the good side, but also on the bad side. So we got to be really careful with our communication with these patients. But we're there to create hope and resilience. So what do people want from clinicians when they have pain? They want to be listened to, validated, and work in partnership with. So we got to ask them, what are your goals? How can I help you get back to your goals? And the patients are saying, I want to know what's going on. I want my life back. What is going on? That's in terms of the diagnosis that Rolf was also talking about, but not just the label, the contributing factor. What are the future consequences of having this diagnosis? Are there some hope for me? What should I do? Also, they need a plan for recovery, control over the pain, get some functional restoration, because at the end of the day, people want to be able to work, lift, move, play with the children, have a quality of life. So on one hand, we have the pain, the distress, the disabled. On the other hand, we have getting back to living again. And then bridging the gap, that's where we come in. And I remind you now that cognitive functional therapy is not a solution for all this. It's just a framework that can be used in guiding people on this journey. And it should be aligned with clinical care guidelines. There's a reasoning framework behind it, and it's person-centered care. So we need to develop this person-centeredness with each and every individual. So in cognitive functional therapy, we call it an integrated whole person approach, and it was mentioned the biopsychosocial model. And we look to coach people to self-manage. in essence, you could say that we try to get people not to need us anymore, and that's really the end goal, isn't it? So in the first part, we're talking about making sense of pain, which is getting a good examination, listening to the story, but also in collaboration with the patient, decide what they need to understand their pain problem. And then we look at how can we put that into behavioral learning. So often we see patients come in with certain movement behavior. Some people have avoided bending, lifting. If it's a shoulder problem, they tend to keep their arms still. If it's a neck, they go around very stiff. And we do this behavioral experiments where we try to guide them from danger at one end and then safety on the other hand. But not just in what we're testing, also we look at how is this influencing all parts of your life. So when you do your grocery shopping, playing with your children, or your work. So it's guiding not just the behavioral experiment from the clinic, but it's introducing that into their activities of daily life, where they feel they get some exposure with control. And I'll talk more about that. But also we deal with lifestyle factors that has been mentioned. Stress, sleep, nutrition, and also social interaction. Because a lot of people feel that they're losing their life in the social dimension. And we know from like the Harvard study that social dimension is probably one of the main or most important ingredients in a healthy life. It's person-centered, again, it's individualized to the person, and we really need to develop this partnership with the patient and the plan. So what does it mean to do a person-centered interview and examination? It means that we explore the story. We have two of those, one of that, and it should be pretty guiding in how that starts the first consult. So we tell them to tell their story. We explore the story together with them. That involves emotions, cognitions, their social life, lifestyles. Are the things they're avoiding? Are they protecting anything? What are the body perceptions? If you ask patients about body perceptions, it's quite interesting how often they come up with something that you never thought of. My back feels like a wall. It's like a stiff tree. It's this thing that I just can't move. And then together explore goals and expectations for the treatment. Again, as I said, this is going through a guided behavioral examination. So if a patient tells me, I can't bend, I can't sit for long periods of time, I'm afraid to lift my daughter, that will be the specific test of that session, right? So they have to go out from there with a feeling that I've really explored the specific problems that they have and relate my treatment to that. So an example here, and I'll show that more, is going through this process from lying to sitting to standing, or other parts where that's necessary. So this is the clinical reasoning process of Joe. So this is just a radar graph showing how he scored. So he was avoidant of activity, he had poor sleep, protective muscle guarding and movement, activity avoidance, social isolated. Often that happens when you're off work. Work duties were light, so it didn't feel like his identity was maintained as a fireman. He had damaged beliefs about his back, negative mindset, he was pain vigilant, he was thinking about his pain a lot, and he had low pain self-efficacy. There was pain-related stress and fear, pain anxiety, and depressed mood. He was highly sensitized, and his MRIs was normal, considering they were findings, but they were normal for his age range. So it was kind of like wrinkles on the inside of his body. And he was fatigued and run down. So his goals were making sense of pain, trying to get some pain control, and trying to get his life back on track. So we developed this personal biopsychosocial understanding, where you take him through all these factors. You're trying to look at what kind of myths he's been told and provide resources, not just in the clinic, but also things that he can go away and read about. Explore his responses to pain, what you feel when you do this and that, and try to promote a positive mindset. Goal setting was linked to valid activities, and also, quite important, is to have a pain exacerbation plan, because quite often we see patients not on a straight line trajectory, but it's going up and down. They're coming in, they have a good day, they have a bad day, or a good week, or a bad week. So it's kind of like reframing from the old way of looking at things to a new way of looking at things. And really, I urge you to write this down for any patient, but it has to be written down in a personalized ways that they've been a part of the collaboration process on. What do we mean creating a positive mindset? Well, it means that pain can affect all aspects of a person's life, that usually movement and physical activity is good and safe. If it doesn't feel good and safe, this is something we have to explore with them. If it hurts, we get them to relax, breathe, try and move differently. This is exploration, so I'm not saying it's one size fits all, but these are the kind of discussions that we have with patients. Pain doesn't equal harm. Backs are strong and can be trusted. It's safe to flex, bend, and slouch. And this is just specific for Joe's case. Then lifestyle support are important, and pathology is common even in people without pain. I must say that if a patient comes in with an MRI, we don't go straight to say, oh, everyone has these findings. But it's trying to explore, what do you think it means to have these, and are you aware of such and such? So it's not just saying that people can have that without pain, but it's how you interact that with the patient. So again, I was just talking about how this takes someone through. I got another, I think I'm going to show this instead. Oops. So, challenging beliefs through behavioral learning. So we identify the provocative movement linked, and we ask patients, what do you feel when you do this? And sometimes you can see them freezing up. If you've done that with a patient that you feel is scared to move, asking them to lift a kettlebell or even just a tiny thing off the floor, they'll go like this and lift it like it's a 200 kilogram weight. We ensure some safety. That means we got to be present and close in. We try to extinguish safety behaviors, people cropping with their hands, holding their breath when they move, and we try to gradedly expose them to the threats. We also do violate expectations. So when somebody is bending in a different way and they feel it's safe, that is a discussion or communication. But what do you think that was? How could you violate that expectation? We then reinforce the new behaviors, reduce the fear, build self-efficacy, and hopefully then can change the narrative from it's dangerous to bend, that it's safe to bend. And we can see this is just an example of within session that you can get people to move quite differently. Generalized learning into valued activities, just mentioned, reduce threats, build self-efficacy. Strength and conditioning is usually quite an important part later on. But I would also say I've seen a lot of people starting with the strength and conditioning, but they're not really prepared because they're like in this sensitized state. So we need to figure out where is the right sweet spot to develop these things and introduce different capacities, if you like. So chase the goals, get back to work, valued activity, social engagement. And it's driven by the patients. It's not us who say you should do this, you should do that. It's asking them, what is important in your life? How can I help you to get back to that? Then this is physical activity, and this is following the guidelines of graded activity, but also being 150 minutes in moderate exercise. I just saw Adam post a new post where he says it's actually now shown that the more vigorous exercise is probably even more important. So again, this changes with the evidence, and we should also change this both to the patient's preferences, but also guide them with what does the evidence tell us right now. So this slide may have to be changed now. That's what I'm saying. Relaxation, sleep is important. We look at how people roll over in bed. So if they have pain with rolling, that's something you can address. But we should also be wary that just giving sleep hygiene and sleep habits advice doesn't solve insomnia and delayed sleeping illnesses. So we should be careful not just to put sleep hygiene to people, but if it's more invasive therapies that are needed, I don't mean invasive, but insomnia, CBT, for instance, is a treatment for insomnia, we should refer on to other people. Stress management is obviously important, relaxation techniques, ask about sleep, try to get sleep better, look at the physical activity and social engagement. And a lot of people are not aware of their stress state, so that's also a thing we need to explore. So exploring the whole person, not just from the movement side, but also inner stress and holding tension and so forth. Then, what about pain exacerbation plan? Because we see patients thinking that it's going to be like that once they start in therapy, but the reality is much more like that. So what we do then is identify the triggers, identify the old responses, the panic, the tense, the protection, and the avoid, and then try to create, reinforce the new responses. And usually when you see patients coming back, I say, stop and think. Try and go through all the different factors. Have you moved differently? Have you moved more? Have you moved less? Has there been stresses in your life? Have you changed your diet? Or are there any social relations? And quite often you'll find something in there, and then you create a plan for that. And of course, if step 1, 2, and 3 doesn't help, then of course they're always allowed to call and come back for a re-evaluation. So this is just Joe's results. And I'm saying this as a disclaimer. Every person up here always shows the perfect ones, right? So we tend to show the ones we succeed with, but not talk so much about the ones we don't succeed. So maybe we should have a conference for failed cases once. That would be interesting. So I'm showing here that Joe, he has an active lifestyle, good sleep. He changed his patterns around a lot of these things. And he changed his mindset. Wasn't in any pain-related distress. He kind of normalized all over. But Joe doesn't represent everyone. And that's why we have to do studies, because we have to see these discrepancies between the responders and the non-responders. So his goal was to maintaining a healthy and active lifestyle and keep going. I have to talk about the Restore trial then, because that's really showing how this work that has been going on for so many years culminated in this Lancet trial that was published in 2023. This was kind of like 2 trials in 1 trial. So it was a trial for the intervention, but it was also a trial for training clinicians from knowledge to competency. So 18 physiotherapists from Sydney and Perth, 20 primary clinics, minimal CFT experience prior, but they had clinical experience, but nobody was like handpicked. But you can say in any study, you'll always get the people who's motivated, so that's obviously a bias to any study that is involved. So what they took them through was this training clinicians to competency. And you can see it looks a bit like observation, understanding, so the knowledge phase. Then in the second part, there is the skills. And I think this is where it's important with learning, because a lot of courses nowadays is revolving around knowledge. It's not so much skills training and competency. And then they had to be mentored, they had to treat patients themselves, they had to get direct feedback from the trainer, all done in a safe space, obviously. And then they developed the competency assessment. It's a bit like driving a car, isn't it? I'm not seeing us going around with an L sign on our front, but you can understand this journey of how do you go from not knowing anything about driving a car to being able to drive perfectly, or not perfectly, but drive well with competency. So what was these competencies? They were in communication, person-centered communication, within validation and cognitive reassurance. It was a biopsychosocial interview, and the interview part, how you develop this kind of, how do you assess behavioral learning. It looks at clinical reasoning, identifying barriers and strength, but also clinical reasoning overall. And then, as I just mentioned, these 3 pillars of CFT is making sense, exposure with control, and lifestyle changes. If you want to go back and look, I urge you to read the paper itself and with the appendices in there. Phoebe Simpson, she also did, she's done some great work on the qualitative side of things. And some of the sayings from the different therapists was pre-training factors. It depends on your own willingness to learn and change and confront your own belief. It's in the learning process. The only way to learn is through exposure. That's what we teach our patients, and it's what we should do as clinicians. You got to put yourself in a scary situation. How many people like to do that? It's not easy for us, is it? Do you film yourself with patients? I think we all should do. It's really valuable, but it's scary. Physiotherapy, culture and context, there's a tendency for a lot of people to say, whoa, what are you doing? That's bullshit. If you're not into their belief of how do you treat pain. I wouldn't say I've mastered it. I would say that I'm competent. There's a big difference between competency and mastery. So who were in the trial? 493 people, so a big trial for low back pain. I'll say that it was a more disabled group than in some of the other trials. They also put people in that was older with the health comorbidities, and a lot of people had actually given up hope. 3 treatment arms, CFT only, CFT with a movement sensor, and then usual care. And before you go bananas on the usual care group, whenever you do a big trial, if you've done a trial, there's always going to be some challenge into which group you compare to. The reason why it was wanted to do usual care was to show the cost effectiveness of how this works in relation to not treating these patients properly. And no care, and usual care wasn't no care, so 70% sought care, and they had 6.5 consultations. And as you saw in the previous slides, there was 7 treatments in the 2 CFT groups, and then they had a booster sessions after 6 months. And the booster session seems sensible because if somebody has diabetes, you just don't go, I'll give you for 12 weeks, and then after that, we don't care about your diabetes anymore. And this is showing the difference. I think I'll go to the minimal clinical important change. That's more understandable. But 60% got to the minimal clinical important change. That's usually an effect size that is deemed appropriate, which is 5 points in this case. And it was almost 70% after 12 months, 19% in the usual care, and 24% after 12 months. The 3-year follow-up was also just published. If you want to read the paper, there's all the secondary outcomes. It's the cost-benefit analysis and everything. But in 30 minutes today, I didn't have time to go through this in more detail. I want to bring you back to Joe. Can you stop the video again?
Zero was probably, well, last time I saw him in his office was probably 4 years ago, 3 years ago. So I've been given the tools to manage on my own, which is just amazing. And I actually found that the times when I do get a flare-up of pain, it's more often than not when I've had a bad night's sleep, or I've got a bit of stress going on, or I'm sick. And these things, it's sort of, they're more correlated with my pain than if I've had a big day digging in the backyard, or a big day of windsurfing, or a big day of surfing. And it's sort of, it just reinforced that idea that pain is not just physical, it's actually extremely complex, but there's a whole lot of facets on which you can actually make it or help it get better. Yeah, so I think maybe the tools can be different for everyone, but for me it's just the idea that the pain doesn't mean damage, and that when I'm in pain, one of the best things I can do is actually go for a drive or do some exercise or work with the pain to show that, well, it sort of just proves to me that I'm still able to function even with the pain, and that's really handy. But then just the idea that you can just relax. You know, if you're in pain on a given day, the idea that, you know, I've been in so much worse pain than what I'm currently feeling.
So I want to finish by this quote: exercise is not the intervention, living is the intervention. I think if you think about it from how we see patients, this is really getting them back to life. I also want to acknowledge thanking the organizing committee for this wonderful conference, and it's my first time in Tirana and Albany, and I'm really thankful for that. Also, I'm just a part of a big group of international researchers, and I'm just here presenting on their behalf. If I have 1 minute, have I? Yeah. I just want to talk briefly about what we've done in the group, and it's we've created this social enterprise, a non-profit organization. And the reason is that we want to really take people on that journey from knowledge to skills to competency. Because we can do another 20 years of research in RCTs, but still, if it doesn't change how people work, it's not going to change anything. So if you want to check that out, there's a free bit there that you can use, and I'm not making any money of this myself, but the money that is going from courses and stuff is going back into research and helping clinicians in low-income countries where they get this whole platform for free. So thank you very much.